Hi, everyone. Welcome to today's webinar session. We will give it one more minute. We will start at 2 p.m. Eastern Time, and we'll begin the presentation then. Thank you. Thank you for joining us. Hey, all right. Hello, everyone, and welcome to today's session. So on behalf of the Special and Vulnerable Populations Task Force, we'd like to welcome everyone to our third webinar of the 4-part National Learning Series focused on comorbidities associated with diabetes. Our webinar today will discuss using health promotion and behavior change to address childhood and adult obesity and diabetes. My name is Joe Lee, and I am the Training and Technical Assistance Director of the Association of Asian Pacific Community Health Organizations, or also known as APCHO. I'm joined by my colleagues, Albert Eisen and Christine Alarcon, as well as Julian Hopewell from the Migrant Clinicians Network, and we will be serving as your moderators for today's webinar. This National Learning Series was created to address our diabetes epidemic, which is affecting more than 30 million people across the US. And to combat and continue the national conversation around diabetes, the Special and Vulnerable Populations Task Force created this series to increase knowledge of effective strategies to prevent, treat, and manage diabetes among health center program patients. 14 National Cooperative Agreement, or NCA organizations funded by HRSA have partnered to create meaningful content and provide access to expert guest speakers for our audience today. We'd like to highlight our NCA partners who helped organize today's webinar. We have Rebecca Young from Farmworker Justice, Silvia Pardita, and Gladys Carrillo from the National Center for Farmworker Health, Darlene Jenkins from the National Healthcare for the Homeless Council, and Andrea Shore from the School-Based Health Alliance. So thank you so much, NCA faculty, for helping us organize today's webinar. So we'd like to give you some brief information about each NCA and to just give you some resources that you can pursue in the future. So I'd like to just start us off with Becca Young. Becca, can you tell us a little bit more about Farmworker Justice?
Sure, absolutely. Hello, everyone. I'm so excited to be here with you today. I'm a senior project director with Farmworker Justice. We are based in Washington, D.C., and we're a nonprofit organization that seek to help empower migrant and seasonal farm workers to improve their living and working conditions, immigration status, health, occupational safety and health, and access to justice. We are always interested and concerned with looking at the social determinants of health to figure out how we can best incorporate the whole farm worker and whole situation in any of the health project work that we're doing. And currently, we are also developing a program that we'll be ready to tell you more about soon that focuses in on childhood obesity, specifically with migrant farm worker children. Thanks, everyone. So excited to be here with you today.
Thank you so much, Becca. Next up, we have Gladys from the National Center for Farm Worker Health. Gladys, can you share with us a little bit about your NCA organization?
Yes, thank you, Joe. As mentioned, I'm Gladys Carrillo. I am the manager of Health Center Engagement Services at NCFH, the National Center for Farm Worker Health. And we are a private nonprofit corporation in Buda, Texas, dedicated to improving the health status of farm worker families by providing information services, training and technical assistance, and a number of products to community and migrant health centers nationwide. We also collaborate with a number of different health organizations, universities, researchers, and individuals involved in serving the farm worker population. So in being a part of this collaborative, we actually have our partners that are going to be speaking here in a few minutes. And so we hope you find this webinar useful and definitely encourage you to check our website for different resources, specifically our newest Diabetes Resource Hub webpage on our website. Feel free to contact us also directly if you need any additional information and resources. Thank you.
Thank you so much, Gladys. Next up, we have the National Healthcare for the Homeless Council, and we have Darlene representing that organization. Darlene, can you share with us a little bit about the council?
Yes, thank you so much, Joe. Good afternoon, everyone. I'm Darlene Jenkins. I'm Senior Project Director. I'm sorry, I'm getting mixed up with my words, trying to rush through. But I am Senior Director of Programs at the National Healthcare for the Homeless Council. We call ourselves the Council. We are located in Nashville, Tennessee, and we provide training and technical assistance, of course, to health centers as well as primary care associations and the HCCNs, helping them to improve quality of care as well as services and access to individuals with unstable housing. We provide many materials and publications and resources regarding the intersection of unstable housing, health, as well as just looking at health equity. So there's some key topics that we're focused on. We really try to also help health centers to engage consumers or their patients in the governance and their work. And so we have many resources for that. So there's our website there. And if you go to our website, many times it can be overwhelming. So if you have a hard time trying to find resources, please contact us and we'll be happy to help in any way we can. Thanks so much.
Thank you, Darlene. And last but not least, we have our School-Based Health Alliance organization with us today. Andrea, can you share a little bit about your organization?
Great, thanks, Joe, and thanks everyone for being here today. I am Director of Programs with the School-Based Health Alliance, and we work to improve the health of children and youth by advancing and advocating for school-based health care. And our work runs a large gamut related to school-aged children, in particular under this funding with to work with health centers to improve their care for school-aged children, and also partner with schools in that process. And we provide the field with high-quality resources, training, and technical assistance to provide that care and collaborate with schools. And we are excited to be here today. So thanks, Joe.
Great, thank you so much, Andrea. Okay, so we'd like to acknowledge HRSA's support in our task force efforts in decreasing the percentage of health center program patients with A1C greater than 9. And we are excited to develop a clinical change package for diabetes care, which will be published later this year. Our national learning series will be utilizing the Diabetes Continuum of Care framework, as you see here in front of you. And today's webinar will be focused on facilitating behavior change in patients as one of 3 main strategies for diabetes prevention and management. Today's agenda will include a 90-minute presentation with a Q&A immediately following, and our learning objectives will be 4-fold. 1, to explore evidence-based programs and strategies to incorporate health promotion and behavior change to address preventing diabetes in adults, and also to the second learning objective here for families with children at risk for diabetes. And our third objective is to discuss promising practices that promote healthy habits, and lastly, to identify challenges in addressing nutrition and physical activity in children and adults of special and vulnerable populations, such as those experiencing homelessness and farm workers. So today, we are super honored to have our speakers with us today. We have Jessica Wallace, who is the Family Medicine Physician Assistant of Denver Health and Hospital Authority. And we also have joining us today, Natalie Bloom, Manager of Prevention of the American Association of Diabetes Educators. So thank you so much, Jessica and Natalie, for joining us. So before I hand it over to them, I want to review a few housekeeping items and let you know how you can participate in today's webinar and engage with our speakers. Here we are looking at a screenshot of the GoToWebinar attendee interface, which is made up of 2 parts, the viewer window on your left and a control panel on your right. The viewer window allows you to see everything the presenter will share on their screen, and the control panel allows you to participate in the webinar. Please note that all attendees are in listen-only mode and will be muted during the webinar. You may submit questions during the presentation by typing them in the questions field of your control panel, and we will be reviewing these questions as they come in and address them in the Q&A session, which will be held after the presentation. When you type in your questions, please direct them to either both or either speakers. That way we know who to direct the question to. So today's webinar is being recorded, so please sit back and relax. All attendees will receive an email with a link to view a recording of today's presentation, as well as a copy of the handouts after the webinar. And you do have the option to interact with us on Twitter at @AppJoeTweets and use hashtag Diabetes National Learning Series. We'd also like to note that CME and CNE accreditation will be made available. Please complete the post-webinar survey if you would like to receive CME or CNE units or a certificate of attendance. You will have the option of indicating whether you prefer an electronic or hard copy of your certificate. And for any questions, you can contact Martha over at the Migrant Clinicians Network, and her email address is noted there. Okay, so let's get started. I'd like to introduce you to our first speaker for today's webinar. It's Jessica Wallace, the Family Medicine Physician Assistant of Denver Health and Hospital Authority. So Jessica, thank you so much for joining us. I am going to give you the mouse control right now. All right.
Thank you so much. Can you hear me?
Yes, we can hear you perfectly.
Great. Okay, so really honored to be a part of this. Again, my name is Jessica Wallace. I'm a PA, that's my day job, but I also work in kind of more public health interventions, and that's what I'm speaking to you about today, using health promotion and behavior change to address childhood and adult obesity and diabetes by providing the example of MEND at Denver Health. Sorry, little click. All right, so I think it's important to kind of give the context here of this is still something pretty new and shocking, I think, to most of us. So current national data show that 1 in 3 children are overweight or obese, and that weight status is closely linked to type 2 diabetes, which, as we all know, used to be called adult onset diabetes, no longer true. Basically, we think what happens when you're overweight is there's this kind of complex host of metabolic changes that happen, and that confers insulin resistance, and that's what provides the risk. Just like with adults, part of the danger with diabetes is just how closely and hand in hand it goes with cardiovascular risks as well. That can be high blood pressure and cholesterol. Age is definitely a risk factor, particularly puberty and all of the changes that happen then. Lack of physical activity is also a risk factor for diabetes in kids, and conversely, increased physical activity has been found to be protective. As we all know, family health, habits, and disease status play heavily into risk for our children as well. And unfortunately, being in a minority group also confers risk, not, of course, because of any genetic underpinnings, but just because of other societal issues that we'll continue to talk about. So the first question here is, what is MEND? So MEND stands for Mind, Exercise, Nutrition, Do It, and it is an intervention that targets school-age children, age 7 to 13, and their parents or caregivers. It's an intensive intervention, so the curriculum runs over the course of 10 weeks, and families meet in a group setting twice a week. The first part of the curriculum is nutrition education and kind of behavioral change support with parents and kids. During the second hour, there's an ongoing parent discussion, and children actually participate in structured physical activity. And these are some examples of some of the tools that are used to teach the topic. So on the left, this is actually a little scratch-off card that kids get to kind of proceed along with group goals. And on the right, these are some demonstrations when families are learning how to read food labels and kind of having a visual representation of fats and sugars available in different foods. There is a practical application built into the curriculum with a grocery store tour. And so as families are learning how to read food labels, then you actually go to the grocery store together, and that provides this kind of direct connection to different habits that families are engaging in. And then, as I said, there is physical activity. This is not a sports team, and it doesn't mimic physical education in schools. This is structured but non-competitive, play-based games that really get kids moving and having fun, and is one of the primary reasons why I think folks continue to come back. It's a very out-of-the-box program. There is a formal training for the people who become MEND nutrition leaders and MEND exercise leaders, and then you get kits. And when you get kits, this includes all of the materials you need to actually implement the program, facilitate the group, and then some incentives for the families as they go along. This is not Denver Health data. This is actually data that was published in the journal Obesity in 2010, and this was a randomized controlled trial that they did in the UK with the MEND 7 to 13 curriculum. And what they found was that they saw statistically significant changes in waist circumference, BMI, exercise recovery heart rate, which is a marker for physical fitness, and improved self-esteem. And those results were seen at 3 months, 6 months, and even sustained at 12 months. And of course, we know RCTs are kind of our gold standard for evidence-based. So that was why seeing evidence like this was important for us at Denver Health. But the next question that we would ask is, okay, so that's fine if you can do it in a clinical research type setting, but how does that translate to the real world? And so starting in 2008, MEND has actually been in the US in different community settings, and they've done some evaluation on that impact and reach. And first off, what for us was really important is that the demographics of the patients that they were reaching in the US really tended to mirror our own underserved populations that we serve at Denver Health. And so that meant that there was potentially a direct applicable nature of the program, and the resources, importantly for us at Denver Health, were available in both English and Spanish. And like the RCT that they did also show statistically significant changes in health-related behaviors. You can see some examples here. Increased physical activity, decreased sedentary activity, reduced sugary sweetened beverage consumption, and increased fruit and vegetable consumption. And again, that also conferred changes in cardiovascular fitness and BMI Z-score. So, think back to that slide about the diabetes risk factors and how many of these directly relate: the weight, the physical activity, and that kind of thing. They also looked at family. This is a pediatric intervention, but because we're targeting the whole family, what's the story with the parents? And of course, we all know that weight is a family issue. And so what they found in those 9 years in the US, fully 90% of the adults were overweight or obese, and that's compared to, roughly 67% nationally. So definitely this is something that parents were struggling with as well. And they also found that about 2 out of 3 parents were able to maintain or reduce their BMI. So even though we're targeting the kids, because of the way families are working together on these issues, that it can have a benefit for adult risk factors as well. And so all of that was really important to us at Denver Health when we were looking at how to address this need, because we didn't want to reinvent the wheel if we didn't have to. And so we wanted to pick something that had a strong evidence base. And so for us, MEND really kind of fit the bill. I put this slide in as a little tongue-in-cheek here. If you're listening to this and you're like, oh, somebody in Colorado, what do they know? This is 2017 CDC map, and Colorado, along with just a couple of other ones, appears to be that, lone green, healthy state. Why are we there? Why are we, worrying about Colorado? Well, it's because poverty is poverty is poverty. This is a map of Denver where Denver Health operates, and what you can see here is darker shades of green corresponding to prevalence rates of pediatric obesity in Denver public school system. And if you look at it, it kind of looks like this L that's been tipped on its side. That if you were to see a map of poverty levels, it looks exactly the same. It mirrors this. And so, when you're talking about rates, you have a lot of areas even in Denver proper that have lower than national prevalence rates for obesity, and then you have a lot that have a lot higher. So that's why Colorado. Denver Health is a safety net healthcare organization. So we actually are an integrated system. We have a level 1 trauma center. We are integrated with Denver Public Health Department. We have our own medical plan. For the sake of this presentation, I work in the outpatient world. We have a network of 9 federally qualified health centers and 17, soon to be 18 school-based health centers. So I don't worry too much about the hospital. I deal with patients in the neighborhoods. And here is a little map, nothing fancy, but I just put pins down kind of where our FQHCs are located, and you can again kind of visualize that L on its side because that's where the need is. And I think it's important to remember that when we're looking at pediatric obesity, that it's not just diabetes, that and sometimes the risks of weight are much more broad than kind of the things we think of at first. And so I'm not going to go through these side by side, but this has been a tremendous burden for our kids to be facing at such an early age. U.S. Preventative Services Task Force recommends that we screen children for obesity, and then we offer or refer them to comprehensive, intensive behavioral interventions. So statistically, when they were looking at all the data, those intensive interventions basically meant 26 or more hours that conferred the benefit in weight status. And certainly at Denver Health, we have demand. Roughly 21,000 patients are overweight and obese in our population. That's not quite 36%. And of course, large numbers of patients with Medicaid or underinsured, minority, Latino populations. Everybody's less than 200% federal poverty level at best. And barriers. So through the years, grants kind of come and go, and there would be other weight management programs in the community settings. But the reality was that very few of our patients were actually participating. And even if they were, we didn't necessarily have a lot of info back to kind of close the loop on, what they were learning, how they were doing, all of that kind of thing. And so we continue to struggle with this idea of how can we best comply with those guidelines, particularly when this is often our day-to-day reality as primary care providers. The other thing is that our patients are sick, and this is by no means a representative sample, but it is some kind of retrospective chart review that we did at one point after we had started looking at MEND. What you can see here is, first off, if we're looking at this like just subset of the population, roughly 44% of kids were being screened for diabetes with an A1C, so there's an opportunity for improvement there. And then I think most strikingly, when you looked out of those that had been given screening, just a little over 50% were actually found to be abnormal, which of course is an A1C of 5.7% or greater. And I think this was really unexpected and just scary. And, that's not the only weight-related comorbidity we were seeing. 14% had elevated cholesterol, 12% had elevations in ALT as a marker for fatty liver, 22% with an elevated blood pressure. And, I think I sometimes wish these things would provide a fever or cough or something that, manifest as actionable. And instead, these things are silent, just like with adults. And so, you really get a sense that weight is providing a tremendous burden and going to continue to provide it in the future unless we know about it and can intervene. So here's just, the sample of the social determinants of health wheel. And I wanted to just very quickly go through kind of what we see and how this can impact our patients. So first off, the low-hanging fruit of health and healthcare. There's so many more layers to it, but at the very least, when you work in an FQHC setting, we know we see patients regardless of ability to pay. So that's how we kind of address that issue. When you're looking at neighborhood and built environment, these are parks and playgrounds and safe sidewalks, crime, food deserts, For economic stability, do people have transportation? Do they have time off from work, or how many jobs are they working? Do they have leisure time? Ha ha ha. Are they enrolled in after-school programs, sports teams? Education, what's their preferred language? What's their health literacy? Social and community context, deportation, violent crime, social isolation. You all know this list well, and there are hundreds more here, but this is kind of just a snapshot of the world we're working in particular in Denver Health. And so in 2015, we got some grant funding, and we decided to integrate MEND into our FQHCs. And so these are 3 actually of the 4 top highest prevalence obesity rates within Denver Health, and so that's where we decided to implement MEND. And basically what we did is that we took a referral from the PCP, and instead of referring out into this kind of ether of the community where we just weren't necessarily reaching a lot of our patients, offering the program in a familiar setting in their medical home. And so, this was our best attempt to kind of address those barriers. And what we saw very, very quickly was high numbers of referrals and high numbers of participants, higher than we'd ever seen for community settings, I think, just because of addressing those barriers. I think first off, it legitimized the program, because if we were offering this in primary care, it showed how important this was to the kids' health. Some of it was logistics too, right? There are patients and their phone numbers change every 2 minutes, but we have multiple means of contacting the patients because they're our patients and they're in our system. And so those are things that maybe in a community setting, they didn't necessarily have a plan B if the number didn't work, stuff like that. What we don't have in an FQHC is one of these. And so given that, a major component of the MEND curriculum is physical activity, we definitely had to adapt. This is a picture of our basement conference room. And you can see we, removed the room divider, we collapsed the tables, we stacked the chairs. And this is probably the best space that we have. We use waiting rooms, we use hallways, we use break rooms, we use parking lots, we use tiny grass areas next to the clinic, kind of whatever we could do. Here's just the gratuitous shot of some of our families when we did our grocery store tours. The kids on the right are very upset to learn that Cheetos are not MEND friendly. And here's some of our outcomes from 2015, 2016 when we were grant operated. So I think we had run 8 of those 10-week programs. And what you can see on the left here, the bolded items, this is the BMI and Z-score, strongly statistically significant, which is pretty exciting. Also that exercise recovery heart rate. We may not have a gym, but it appears that our space was still plenty sufficient in order to see those changes. And the other items that are listed here relate to those health behaviors. So again, looking at the risk factors for diabetes and other chronic diseases. And these last 2 here, the difficulty score and the body image score, this relates to kind of mental health, psychological well-being, body image, and self-esteem. So it's really cool that we had a positive impact there as well. I don't know where's the one. Okay, so I hesitate to show these data, but we have looked, and so I just want to let you know this is the teeniest, tiniest N you'll ever see. But as we got further along into implementing MEND, we started to look at our patients who started MEND, had these comorbidities, and then what happened to them as they would continue in MEND. And so it does at least appear that A1C will go down. Here is the same with abnormal ALT, and again, an even smaller end, but a more significant change and drop off. And then same with hyperlipidemia, and you can see here baseline and then post-MEND. Again, what we're hoping is that this is just, are we on the right track? And then as we see more and more patients participating in MEND who have these comorbidities, does the N get bigger, and then we can study those changes and have an even greater impact there. We also have looked a little bit at parent and caregiver impact when you participate in MEND, and so there is a survey as well for parents. And so it does look like they also changed their health behaviors. Here's just an example of fruit and vegetable consumption. There is a separate mental health score and screening for the parents, and that also improves pretty significantly, which we all know that how much that can relate to the ability to make changes and do hard things. Parental BMI, we had a much smaller N. We just weren't as thorough about collecting that pre and post, but it does look at least like there is the potential for some improvement there as well. So we're hoping to get a little bit more rigorous there. And so, excuse me, this is going to be a busier slide, but I do want to kind of go through it line by line. If you're listening on this call and you're like, well, I don't live in healthy Colorado and I don't work with an urban population or whatever it may be, I think you can apply these same approaches to the SDOH issues that you find. So bear with me here. Looking here at the top, we know that time and work commitments are going to be a barrier to families participating in such an intensive intervention. And so how do we facilitate families participating? Well, we did focus groups and we asked them what their ideal days of the week and start times were. Language and health literacy. A lot of our families were Spanish first language, low literacy levels. Well, so we started to facilitate the class in both English and Spanish concurrently. And then over time, we simplified the surveys. Once we felt really confident that we had good behavior change, we shortened the surveys a lot so they weren't so much of a burden and we didn't have to keep assessing the same things over and over. Let's say you have an inflexible job, your employer won't let you have time off to bring your family. Over time, we changed it so there's no punishment for missing classes. It's less of you attend from week 1 to week 10, and instead you come when you can. And don't worry if you miss a bunch. We're here, kind of reconnect back in whenever you can. Life stress. So families often faced extreme challenge during the 10-week participation, and that's not well addressed in a group setting that's dealing with weight. And so the good thing about being in-house is we were able to connect them to some of our other FQHC resources like social work and behavioral health. You also have a lack of safe spaces for physical activity. And so even though families knew that they should and even wanted to add physical activity, they just weren't able to figure out how to make that happen. And so we added a drop-in 1 class a week that's just exercise only and fun. Food insecurity, of course, families struggle to buy healthy foods even once they learn and have the knowledge to be able to decide. So we've done some partnering with local food rescues and the health risks, like I mentioned. So what are we doing about the diabetes and prediabetes and the other risks? So we've kind of added on an additional layer of provider visits to help improve the medical management. And again, we're hoping to have more data on that with time. So this is more an idea of, you just kind of systematically, take a look at your individual patient population and figure out how can we best adapt it to meet their needs. And so just to relate it back to diabetes risk, this is actually data from kind of system-wide by one of our pediatricians that was published in Pediatric Diabetes in 2017. And they found that in youth with prediabetes range A1C, BMI stabilization was associated with improvement of glycemia. So, that's what we're here for, is to keep families healthy and happy for the long term. And so this is my contact information as well as information on the MEND program and how you can get more information on how to partner with them and do trainings and things like that. And I'll turn it over to my colleague.
Great. Thank you so much, Jessica, for that wonderful presentation. We are receiving a lot of great questions in the question box of the control panel, and we just want to remind folks that everyone is in listen-only mode for today's webinar. However, you're more than welcome to jot down, plug in your questions, and we'll be able to answer them at the end of the presentation. And several people have asked if they'll be receiving a copy of the slides for today. If you look in the handout section of the control panel, you can download a copy of the slides for today, and we'll definitely email you a copy afterwards. So thank you once again, Jessica, for this presentation. That was really great. I would like to introduce the next speaker for today's webinar, and that's Natalie Bloom, the Manager of Prevention of American Association of Diabetes Educators. So Natalie, thank you so much for joining us today. I'm going to be giving you the control panel, the mouse control in just a moment. Okay, you should have the mouse control right now.
Great, thank you. So thank you all for allowing me to present today. I'm excited to talk to you a little bit more about the National Diabetes Prevention Program. My name is Natalie Blum, and I'm the Manager of Prevention at the American Association of Diabetes Educators. Sorry, I'm having a little bit of difficulty finding the slide control, but a little bit about our organization. We are a membership-based association, and we have a wide range of healthcare professionals underneath our membership, including nurses, dietitians, pharmacists, among many other healthcare professionals. And as an organization, our role is to ensure that they have the highest level of education. We provide educational courses and resources to ensure that these individuals can provide the highest quality of care to the patients that they are seeing with type 2 diabetes, type 1, gestational, as well as pre-diabetes. We are also a national accrediting organization for Medicare and diabetes self-management education. To give you a bit more background on how we got involved in the diabetes prevention space, we conducted a national practice survey back in 2010, and we found that our members were already working with patients with prediabetes, and over 80% of the diabetes self-management education programs that we work with were already offering some type of preventative services. So it only made sense as an organization for us to get involved in this space. So since then, we've had the opportunity to now participate in 2 5-year cooperative agreements with the CDC to scale the National Diabetes Prevention Program across the country. And more recently, the current grant we are working on is focusing on working with priority populations in underserved areas that have little or no access to diabetes prevention services. So I'm really excited to talk a little bit more about this evidence-based program with you. But before we dive in, I did have a polling question. So I wanted to get a better understanding of who on the webinar today is actually familiar with the National Diabetes Prevention Program. So you should be able to see a quick poll on your screen, and go ahead and input your answers if you've heard of it, or if you've not, and we'll give you about 10 or 15 seconds to fill that in. All right, so a good percentage of you have already heard of the program, which is great, about 62%, and then 38% of you have not heard about the National DPP. So this information might be a little bit new to you. All right, so this iceberg is a very common image that you may see when we're referencing diabetes and pre-diabetes. This top portion above the water really represents the 30 million people that have diabetes, where this much larger portion below the water represents the 84 million U.S. adults that have pre-diabetes. That number is huge, and there's a lot of work that we need to do to try and reduce those numbers. Of those 84 million people that have prediabetes, 9 out of 10 people do not know that they have it. Prediabetes is associated with other conditions, chronic conditions like kidney disease, heart disease, hearing loss, and vision problems. What we also know is that racial and ethnic minorities are at substantially higher risk for type 2 diabetes. So in order to address these health disparities, interventions do need to be put in place, and they need to attend to the cultural factors that increase engagement of ethnic minority populations in prevention programs. So what can we do to help specifically high-risk adults reduce their risk for type 2 diabetes? The Diabetes Prevention Program was a major research study that tried to find out whether losing some weight through improving diet and increasing physical activity could prevent or delay type 2 diabetes in its study participants versus the drug metformin. All of the people in the study were overweight and had prediabetes, and almost half of the participants were from minority groups. There were over 3,000 participants that were in the study, and they were randomly divided into 3 treatment groups. The first one was a lifestyle intervention. The other members were put into a medication group and received the drug metformin, and the third group was a placebo group. The results from this study showed that structured lifestyle change programs had the largest impact. Participants achieved a weight loss of 5 to 7% of their body weight and reduced the risk of developing type 2 diabetes by 58%. The medication group was also successful, but only saw a 31% reduction. The other interesting findings were that the outcomes were the same across all ethnic groups, socioeconomic statuses, men and women. However, for those that were 65 or older, it reduced their risk by 71%. The results of the DPP research study do suggest that millions of adults in the U.S. with prediabetes can lower their risk for type 2 diabetes by losing modest amounts of weight through decreased fat and calorie intake and being physically active on a regular basis. Also, what we know from this study is that weight loss was the most important factor in reducing one's risk. In this specific study, fat calories had a pretty large influence on weight loss. One thing that I do want to mention is that the National DPP isn't solely focused on fat grams, but it is discussed throughout the program. So moving diabetes prevention from research to implementation in communities was a major undertaking. In 2010, CDC actually established what we now know and what is called the National Diabetes Prevention Program, also referred to as the National DPP. This is actually a partnership of public and private organizations working to prevent or delay type 2 diabetes by delivering evidence-based programming. More recently, there has been a strong effort to bring effective lifestyle change programs to underserved areas and priority populations across the country. A little bit more about the program. It is a year-long intensive lifestyle change program. It's really broken up into 2 different phases. The first phase is months 1 through 6, where organizations are delivering programs on a weekly to bi-weekly basis. The second phase of the program is called the core maintenance phase, which is months 7 through 12, where an organization is then transitioning to providing educational sessions, a minimum of once per month. The program is really built on having individuals develop healthy behaviors such as eating healthier, increasing the number of physical activity minutes they're engaging in, as well as coming up with problem-solving skills. The DPP can be delivered in a wide range of settings, including right within the community or within the clinical setting. The DPP is conducted in a small group format. There is an approved training curriculum. It is also delivered by a trained lifestyle coach. So a lifestyle coach can be either a healthcare professional, such as a nurse or a dietitian, but this program can also be delivered by a community health worker or a farmatora. They've actually been able to show through research that an individual that is a community health worker or farmatora can deliver this program with as much effectiveness as a healthcare professional. A common issue among participants and adults is that most individuals have tried many fad diets or popular diets and have seen weight be gained back. The difference with the National DPP is that it is not necessarily, or the mantra of the National DPP is that it's not necessarily a weight loss program, but rather a diabetes prevention program. What often separates the lifestyle change programs from fad or extreme diets is the ability to sustain them for a lifetime. It is evidence-based and is flexible, allowing individuals to make their own choices. The lifestyle coach or the lifestyle change program works with groups of participants to reduce their risk for type 2 diabetes. The primary goals of the program are for an individual to lose 5 to 7% of their starting weight and to work up to 150 minutes of physical activity per week. One of the most important messages that is demonstrated within the program is tracking and self-monitoring. So throughout the entirety of the program, participants are asked to track many various things, including calories, fat grams, their physical activity each week, which are then discussed amongst the other group members. And it's also an opportunity for the lifestyle coach to provide suggestions and feedback. The program is also really built on that group dynamic and that group process. All right, so who is eligible for this type of program? All participants that are interested in engaging in the National DPP do need to be 18 years of age or older. The research and the evidence that was done on this program was done with adults, so you do need to be 18 years or older. All program participants must have a body mass index of 25 or greater, or for those that are Asian American, it's 23 or greater. Program participants must also be considered eligible based on either a blood-based test, and there's a couple of different blood-based tests that can indicate if an individual has pre-diabetes. One of them is a fasting plasma glucose between 100 and 125, an A1C between 5.7 to 6.4, or if you've had a clinically diagnosed, or if you've been clinically diagnosed with gestational diabetes during a previous pregnancy. Participants may also be eligible based on a positive risk screener that is provided by the CDC. It's a 1 to 2 minute test that can be done either on paper or online, which will indicate whether you are at high risk for prediabetes. The other items to consider or to be aware of are that participants cannot have a diagnosis of type 1 or type 2 diabetes prior to enrollment before engaging in this program. So I do want to do a really quick case study. So you just heard me talk a little bit about who is eligible for this type of program. So up on your screen, you'll have an individual, and what I want you to do is identify if this individual would be eligible for the National Diabetes Prevention Program. So you can see here we have a Hispanic man that's age 39. He works in California Central Valley as an agricultural worker. He has a BMI of 24. He has an A1C that indicates that he has prediabetes of 5.8, and he has actually received a positive test showing that he is at high risk for prediabetes, and both of his parents have passed away from complications of type 2 diabetes. So I'll give you all just a second to think about it. You can go ahead and put your answers into the chat box as to whether you think he has or is eligible for the national DPP. I'll give you about 10 seconds or so. So the answer to this is actually that this individual would not necessarily be eligible for the national DPP. He meets the age requirements. He also meets the blood-based test value. However, unfortunately, he is showing that he only has a BMI of 24. So in order to be eligible for this program, as I mentioned, you do need to have a BMI of 25 or greater, or if you're Asian American, 23 or greater. So it's a little bit of a trick question. Okay. And although a participant may or may not be eligible for this program, it is important to assess their readiness to change and willingness to participate in a year-long intervention. A year-long intervention is a big commitment, so we want to ensure that they're really ready for this type of lifestyle change. Lifestyle interventions like the national DPP have shown to be effective in reducing one's risk for type 2 diabetes, but maintenance is still difficult. If participants enroll in the program resistant or unwilling to change their current behaviors, they are less likely to be successful and reach their goals. So we all know that change is hard and it is rarely a simple process and usually involves a pretty substantial commitment of time, it takes effort, and it can be an emotional adventure. I do want to briefly touch on the stages of change, which are strongly encouraged by programs and lifestyle coaches to assess prior to enrolling a participant. The first stage is the pre-contemplation stage. So this is the stage when the individual is usually not intending to change in the very near future. They're either unaware that they're at risk, they're unwilling, or they're discouraged by change. It's really the lifestyle coach's job and responsibility to help this individual raise awareness of the risk of type 2 diabetes and to show if they are or have them try and take a risk screener to see if they're at high risk. It's an opportunity to show empathy towards that individual and really help them move along these stages of change. The next stage is the contemplation stage. This is where the lifestyle coach might evoke change talk or motivate and increase an individual's confidence, help them resolve any uncertainty that they have. And next is the preparation stage. So this is where one intends to take action but has not necessarily done so at this point in time. So the coach will want to build on that individual's motivation. They'll want to build skills. They want to help that individual come up with their own action plan. And from there, we hope that individuals will engage in these evidence-based interventions like the national DPP. Most program participants will or have cycled through the changes of stage several times before they actually settle and commit to an intervention like the DPP. One significant feature of the readiness ruler or change talk ruler is that participants assess their own readiness by marking the ruler or voicing a number. So some questions as a lifestyle coach that you could ask would be focusing on the benefits of change for that individual. You'd want to focus on prior successes that they've had in other programs. You'll want to look and vision or see what the vision of that individual is and what they see their future change being. So this is a common tactic that is used for the lifestyle change program. Some other readiness tools that are available and resources that are available are a readiness to change survey. So AABE has it's called the AABE 7 self-healthcare behaviors. Some of you may or may not have heard of it. So we have actually developed one very similar, but it's focused on the national DPP and those with pre-diabetes. We do have that available for individuals that are interested in it. Some other tactics that we've seen programs use when implementing the national BPP is offering an introductory session or a session 0 before they actually go and implement the program. This is an opportunity to show program expectations with potential participants and really establish some buy-in with the participants. Other things that you can do and that we've seen be effective are asking potential participants to sign commitment agreements before enrolling and participating in that first session. That really helps them acknowledge and commit to the program's expectation and requirements. Some other components of the DPP include the staffing of the national DPP. So if you are interested in becoming a DPP provider, some things that you should consider are that you'll need a trained lifestyle coach. We actually recommend between 1 to 2 trained lifestyle coaches at each organization. You also need to consider your own organization's capacity, so you may want to increase that as well. You'll also need to have a program coordinator on hand to connect with. They really are the individuals that are providing oversight to their trained lifestyle coaches. They're the ones that are out in the community marketing this program, establishing relationships with healthcare providers and community partners in their area. They're really the ones that are trying to drive referrals into their program and working towards becoming a sustainable program. Another big key element of the program is there is quite a bit of data and tracking that is required on behalf of the CDC, who's the one that's leading this program. So it's really important that you have a data specialist on hand. So someone that can record data based on your participants and how they're performing the program. So someone that's looking at, you know, how many sessions did that participant attend? What was their weigh-in for that day? How many physical activity minutes did they get in for that week? I do want to spend most of my time really focusing on the lifestyle coach. As a lifestyle coach, you do not need to be an expert in diabetes to lead this type of program. It is not their role to give specific information on diabetes or any other medical condition. But what they do need is the ability to facilitate a group and use the curriculum to help participants develop the skill sets they need to adopt a healthy lifestyle and also empathize with the individuals going through this program. Lifestyle coaches engage group dynamics to build accountability and seek solutions to barriers and challenges and really reinforce learning amongst their group members and amongst the participants in the group. Before I talk about the techniques for a strong lifestyle coach, I think it's important to understand that this program is truly built on group dynamics. Throughout the program, participants are encouraged to share with their group any problems or challenges they are facing related to lifestyle change. In turn, the group then brainstorms different ideas and solutions to address some of those issues that they've brought up. The group dynamics helps to build an expectation that the participant will try to identify issues that are keeping them from achieving their goals, and then develop potential solutions with their group members. And then what happens from there is they test out those solutions in between each of those group sessions and then talk about it when they get back together. The goal of the lifestyle coach is to promote those group discussions and then follow up with the participants in the group setting to find out how they responded to those solutions. So lifestyle coaches utilize group facilitation and motivational interviewing techniques to discuss topics and sessions throughout the year-long intervention. Group facilitation taps into techniques and principles such as adult learning, accountability, and support. But we want to help facilitate an individual's decision-making process to elicit internal motivation. It uses an interactive, empathetic listening style to increase motivation and confidence among its participants. And these are skills that a lifestyle coach will learn to have once they've actually gone through a lifestyle coach training and they have the opportunity to start to facilitate and actually engage in some of the sessions. You'll see two links on your screen. I really like these two links. They share examples and strategies for motivational interviewing related to diet and exercise and obesity. So if you do get a chance after this specific webinar to check those links out, I do highly encourage you to take a look at those. When communicating with individuals, some core practices of group facilitation include active listening, asking participants questions, paraphrasing, synthesizing ideas, offering clear summaries, and giving and receiving feedback. So some examples of some group facilitation techniques that are commonly used by lifestyle coaches when implementing the National DPT include open-ended questions. So open-ended questions really elicit descriptive responses from participants. Another technique is nonverbal support. Nonverbal techniques, these are really used to support participants and create a comfortable environment. Ping-ponging. So ping-ponging is really when you're directing a response back to a participant who's asked a question and then engaging the entire group on a subject. Another example of a technique is the carousel. This is a really great technique to use when you're trying to engage the entire group to participate in a session. You can actually either pose a question or engage in an activity which the participants take turns responding to the same question that you propose. Cross-questioning. So cross-questioning is when you're directing a question from a participant to another person to actually respond to. Subgroups are a common technique that is used in sessions. They're also another really great way to make participants feel comfortable when they're engaging in conversation. You might have a couple of participants in your program that are a little bit more shy or aren't participating on a regular basis, where subgroups might make them feel a little bit more comfortable. But basically, this is where participants are paired off or gather in small groups to discuss various topics. Active listening. So this is a structured form of listening where speakers feel understood, they're acknowledged, and it's an opportunity to encourage participants to really share how they're feeling and what's going on in their everyday life. So a good example of this is using good eye contact and nodding and things like that. So I do want to do a quick polling question. So I wanted to see what technique is being used by the example on your screen. So here we have a lifestyle coach who is proposing a question to her participant, Iris. So the question is, Iris, can you answer Dave's question of what we mean by a healthy way of eating? So you can see you have a wide range of options on what techniques you might be utilizing. So I want to give you all a minute to try and put your answers in the chat box, and then we'll discuss it a little bit more.
Thank you, Natalie. This is just to, this is Joe. I just want to direct the audience to the chat box of your control panel. Feel free to input your written response there. You should have an option to chat the organizers and panelists or directly to Natalie as the presenter. So please feel free to type in your response. Thank you.
So the technique that's being used here, hopefully everyone got a chance to put in their responses. So the technique that is actually being used here is cross-questioning. So again, that's when you're directing a question from a participant. So here it's from Iris and directing it to another person in your group. So the lifestyle coach has engaged Dave to try and answer Iris's question. Great. So the CDC does offer a curriculum which provides a facilitator's guide as well as participant handouts. It is available in English or Spanish. It's called Prevent T2 or Prevenga 2. And the curriculum offers tips on tailoring sessions to meet participants' needs and preferences. It includes cultural considerations. It does take into consideration low literacy as it was developed at a 5th grade reading level. The Spanish version of the curriculum is not a direct translation. It was actually developed independently. It did get significant input from native Spanish speakers. It also incorporates culturally appropriate examples of food measurement, and physical activity. And it is intended for Mexican Americans as well as other Spanish-speaking members of the U.S. population. If you are interested in offering this curriculum in other languages or to other populations where you did want to tailor it, you do always have the opportunity to send CDC your own curriculum and they can approve that. So that's always an option as well. Again, the great thing about this program is you have flexibility on how you present the material, which allows you to tailor and adapt the program to the unique needs and interests of your participants. So the Prevent T2 program reflects new literature on self-efficacy, physical activity, and diet. There are actually 26 different modules through the curriculum. The first part of the curriculum really focuses on skill building, and the second part is really responding to those external environmental issues and those psychosocial aspects of lifestyle change. There is a balance between increasing awareness of what and how individuals are eating and learning the actual techniques that replace those unhealthy behaviors with healthy ones. So you can see here just a few of the topics that are discussed throughout the entirety of the program. So we have examples here such as getting active to prevent T2, eating well to prevent T2, tracking your food. Here are just a few more which talk about burning more calories than you take in, managing stress, finding time for fitness, and many, many more. So I just want to talk about some of the key messages that are described in some of the sections that give you just a glimpse of what the content looks like. A lot of time is spent on discussing healthy eating and physical activity. Throughout the program, participants discuss ways to eat healthy, including regular snacks, slow and mindful eating, not worrying about cleaning their plate, and eating in a calm environment without distractions. Tracking is the #1 predictor of success in this program, so participants are asked to track what they eat and their physical activity on a weekly basis. And yes, this is a challenge for our participants. We've heard this from many participants in the programs that we work with, that it's where we have seen the most success, and it gives them an opportunity to really think about the foods that they're eating. It gives the opportunity for the lifestyle coach to give feedback and see if a participant is plateauing at any point. It allows them to address, what's happening on a day-to-day basis. Also discussed throughout the program, they do talk about tracking and some of the challenges behind it and how they can work through the barriers of tracking. Some other things that are talked about in some other sessions is focused on burning more calories than you take in. The calorie balance represents the relationship between calories in, so for example, what you're eating, and calories out, which is your physical activity. This focuses on how to reach the point where the calorie balance trips towards weight loss, and the calorie balance is all about energy in and energy out, and calories in and calories out. So a focus throughout the lifestyle change program is on fat gram reduction because it is the most calorie dense and simple to track. However, there is certainly plenty of discussion surrounding calories. Participants are given the option of tracking their calories as part of their daily self-monitoring, but a calorie goal is not officially included in the lifestyle change program. The only time calories or a calorie goal is given is if an individual is behind on meeting their weight loss goal. But again, participants are encouraged to self-monitor their calories and what they are eating and lower their intake levels to really support their weight loss. For some participants, meeting the fat gram goal will be enough for them to achieve weight loss, but for others, a fat gram goal alone will not be effective, which is why we talk about calories in general. So a little bit about physical activity. So this is a large component of the program. The goal is to have individuals reach or work up to 150 minutes of physical activity per week, which is built gradually over time as they go through the program. The intent of the National DPP is to really encourage all types of physical activity and really figure out what's going to work and what's going to stick for that individual. So there is a focus on discussing, moderate physical activity and things that you can engage in. It really encourages activity of at least 10 minutes, that an individual is engaging in at least 10 minutes of physical activity, and that they're trying to do it a minimum of 3 times per week. We have seen sessions be adapted based on, really taking into consideration what groups and what populations that they're working with and what is going to be favored among those groups. Some examples of that we've seen are organizations that are working with Hispanic communities. A lot of times they prefer engaging in activities that involve things around music and dancing. So one program that we are currently funding and supporting has incorporated Zumba into their sessions to try and, really encourage programs to try different forms of physical activity and really find something that they find fun and that they can continue to engage in. So I already talked about that a little bit. Okay. So as I mentioned, there's a lot of flexibility in how the programs can be presented, and it is very important for the facilitators to understand their community and the populations that they're working with. Some other common examples of cultural adaptations done by programs across the country have included offering the curriculum in multiple languages, modifying the words of the program to incorporate cultural sensitivity, so really understanding that some of the populations that you might be working with are low literacy, or, presenting the program or presenting the sessions in a language that works for your target population. Also considering how you're delivering the program. We've seen organizations offer this and have lifestyle coaches that are either community members, peer educators, community health workers, or promotors, really those individuals that are going to relate more to the program participants and really be engaged more and feel like they're understood by that lifestyle coach. Some other ways that we've seen the program be adapted was based on the way that it's being delivered. So the program can be delivered in a wide range of modalities. It can be done in person, it can be done online or virtually, it can be done using distance learning or a combination of those. So, when you're thinking about the populations that you're working with, are you working with a very transient population like a professional driver or, an agricultural worker who might not necessarily have the opportunity to participate in such an intensive program in person? Maybe looking at a program that's either done via distance learning or, a combination of in-person and distance learning might work better for that organization and that individual. Also really looking at, you know, when discussing healthy habits, really looking at your study population, your participants, what's going to be reflective of that population. So using foods and activities that are relevant to that population. One thing that I did want to mention was, you know, we're starting to look at various priority populations like Hispanic and Latinos, African Americans, and really trying to better understand how this program can be adapted to them. We have been working with one program that has looked at or has provided a cohort at a homeless shelter, actually known as New Hope Housing. There's not a whole lot of research or supportive research that has been done to date with this specific population. There are a lot of barriers to providing this type of intensive program to this population, but that's not to say it couldn't benefit them. The one organization that we have worked with that's provided this at a transitional home has provided it actually to 6 participants. They started this cohort back in August, and unfortunately they're already down to 3 participants. Some of the things that they had mentioned as being a challenge for this group and this population is that the residents were very challenged by committing to the program because many of them would find new jobs and just not have the time to commit to this type of program. Also, when they were implementing the program, really to engage their participants, they had to put in place incentives. So that got the individual in the door for the first couple of sessions, but they weren't fully committed to the program. So there's a lot of barriers and challenges to addressing homelessness with the National DPP. So we're still trying to learn more and more about working with this population. All right, so while over thousands of organizations across all 50 states are offering the Lifestyle Change Program, there are still many areas with few or no programs. So many priority populations have been under enrolling. So we need to try to continue to serve as many individuals as possible. We want to encourage you as potential DPP providers to consider learning more about the National DPP and how you can actually become a DPP provider. The CDC actually offers an organizational capacity assessment, and this assessment is a really great tool to take a look at if you're considering becoming a provider. It can better inform you of items that you should consider before becoming a DPP, or things that you might want to first address before putting your DPP in place. You can actually go to the CDC website, and they will have that capacity assessment on there, and it's easy downloadable from there. And lastly, I just wanted to say AADE does offer a wide array of services to support both new and existing DPP programs. So we do offer services such as lifestyle coach trainings, a Building Your DPP workshop, which is really built for that program coordinator, or if you're an organization that's considering becoming a DPP provider. It talks about everything from how to market your program to who would be a good lifestyle coach to really looking at the reimbursement landscape. We do have a database platform that can help organizations. So we're just one of a couple of organizations that have built many services and resources that can really support organizations that are interested in becoming DPP providers. So I encourage you to seek out those opportunities and really take advantage of some of those supportive resources that are out there. So again, my name is Natalie Blum. I'm happy that I had the opportunity to talk a little bit more about the National DPP. You can see my contact information on your screen, so if you do have any follow-up questions after the webinar, feel free to send me an email. But otherwise, thank you.
Great. Thank you so much, Natalie. That was a really great presentation. We are huge fans of the Diabetes Prevention Program, so we really appreciate you for being here today with us. Great. Okay, so we will now begin the question and answer portion of our webinar. And as mentioned at the beginning, we will start by answering questions submitted to us that were submitted to us during the presentation. If you would like to submit a question now, please do so in the question box on the right-hand column of your GoToWebinar screen. So our first question is for Jessica. One of the attendees asked in terms of how they can get a copy of the childhood obesity medical complications poster.
Great question. I think I just have it in a JPEG and I found it online. So it's definitely in the slideshow handouts, but let me see if I can find it just as its own image, and I can pass that on to you all.
Great, thank you, Jessica. Feel free to, you're welcome to just send it to us and we can email it out to all the attendees today. There's a couple more questions for Jessica. What is the application and compliance process for MEND like? And who runs the MEND program? Are these health professionals like nurses or physician assistants?
Great. Okay. So first off, in order to kind of become a partner site for MEND, you basically just reach out to them on their website. They have a couple of different versions of their program. A lot of their staff are based in the UK, but some are based here in the US, and they certainly have lots of US partners. You know, basically you set up a phone call with them, talk about kind of the scope and scale with which you're looking to do the program, and then they go through and provide you all the details on the next steps. I mean, like I said, there's definitely a training that takes place, and then you kind of purchase the kits and do the program like that. In terms of who runs it in our organization, so those staff, like the nutrition leader and the exercise leader, those are really meant to be kind of lay folks. You don't have to have an RD or that kind of thing, which we don't in our health centers. And so honestly, we've been doing this since 2015. Anymore, most of the time, those folks are medical assistants or even clerks that work in the health center who just want to diversify their role, and so they go through the training. You know, not everybody wants to learn how to facilitate a group, just like with DPP. I feel like that's a different skill set that you can be easily taught, but you have to be okay with, you know, interacting with a group of people and leading those conversations. So, but that's how we've had the most success. And then we do also add on the kind of medical component as well now, and that is run by either PAs or NP or nurse practitioners.
Great, fantastic. Thank you so much, Jessica. We have a few questions for Natalie. Natalie, earlier you described some key group facilitation techniques. What would be an example of nonverbal support? Can you provide clarification on that?
Sure. So some examples of nonverbal support could be anything from you utilizing good eye contact to, you know, nodding and acknowledging when a participant or an individual is speaking to you, smiling, things like that. Those are examples of nonverbal support.
Great, thank you. And another question from an attendee. They asked, based on the case study, the attendee is wondering why someone who is at high risk not eligible to participate in the diabetes prevention program.
Sure. So for the example that I gave you, so the participants, there's two requirements that all participants in your program must have. So they must be 18 years or older, and they must have a BMI of 25 or greater, or 23 or greater for Asian Americans. In addition to those two requirements, they either need to be or have a blood-based test indicating prediabetes or have that positive risk screener. So for the case study that I provided, although they had a blood-based test indicating proof that they had prediabetes, they didn't meet that BMI requirement, which is required of the CDC's national DPP.
Great, thank you. Another question for you, Natalie. Are there differences for each DPP depending on the state? One of the attendees mentioned that for their program, they're allowed to use the A1C between 5.7 through 6.4.
I'm sorry, can you repeat the question?
Oh, yes. The question was if there are differences in terms of, it sounds like differences in eligibility for each DPP, for each diabetes prevention program, depending on the state or the location that they're based in. One of the attendees mentioned, yeah.
Yeah, so the programs are actually implementing the CDC's national DPP. The requirements as far as participant eligibility should be the same across all programs in regards to the CDC's REG program. So the blood-based indicators that I provided, there are the requirements and what is given by CDC's recognition program. The only time there might be variation is if you are a Medicare DPP supplier. Their requirements as far as blood-based tests do change. The only other time it might also be different is if you're working with various payers or private or public payers. They might have different requirements as far as what the eligibility requirements might be and what an individual might be eligible based on a blood-based test. But as far as CDC's requirements are concerned, what's provided here should be the same across all DPP programs.
Great, thank you. And one last question is, what's the recommended group size, in your opinion, for an in-person, in-person T2 group?
Yeah, so what we've seen is really that sweet spot for organizations is really trying to have a cohort of between 12 to 15 participants. That ensures that there's a really great dynamic and conversation happening amongst the group participants and the facilitator. It's still a manageable size for that facilitator to handle and control. And it also helps you when you're really trying to meet CDC's requirements as far as data is concerned and as far as trying to meet their recognition requirements. If you do have a smaller group, it can affect some of your data and some of your outcomes because CDC looks at averages. So what we found is that, 12 to 15 participants is really that sweet number.
Great, thank you. And just one more. If an organization is interested in starting a Prevent T2 group, is it required for the organization to apply to be a CDC recognized program in order to start this Prevent T2 group and use the curriculum?
So we strongly encourage you to become a CDC recognized program. It's really built off the evidence. It ensures that you're providing the program with quality and fidelity and really how it's intended. So, we encourage you to do that, but if you choose not to, you won't be penalized. The curriculum is available on the CDC's website for free. So you can download it at any time and you do have access to that curriculum. So you don't have to become a CDC recognized program, but we encourage you to.
Great, thank you, Natalie. Well, I think that's all the time we have for questions. And I just, again, want to thank our speakers, Jessica Wallace and Natalie Blum, for today's wonderful presentation and everyone for their time to attend our learning session today. We just want to remind folks that we have one more webinar coming up in our 4-part National Learning Series. And this is happening next Tuesday, April 23rd, where the webinar will be focused on using the community health worker and enabling services workforce to address social determinants of health and diabetes. And this webinar will be hosted by the following organizations: APCHO, Migrant Clinicians Network, MHP Salute, and the National LGBT Health Education Center. So to register, please visit our website at diabetes.apcho.org. You can find more information and the registration links there. If you missed our first 2 webinars of the series, you're welcome to visit the website diabetes.apcho.org There you'll find the PowerPoint slides and recordings for these webinars, which are now available. We ask that you kindly take 30 seconds to complete the survey you will receive after today's webinar. We rely on your feedback to improve our resources and ensure we are addressing pressing issues and challenges that are relevant for your health centers, patients, and staff. So for more information about our National Learning Series, please visit diabetes.apcho.org. And you're more than welcome to contact our speakers, whose contact information is listed here in front of you. Thank you so much for attending today's session, and have a great rest of your day.